Thank you, Peter. Disclosures. In a nutshell, because we're running out of time, good indications, suitable anatomy, detailed informed consent, decent inventory, good echo support, proper sizing, good closure technique, try to avoid complications and have some follow-up. So good indications, well, these vary, but essentially you need some hemodynamic load, pulmonary to systemic flow ratio 2:1, pulmonary hypertension, definite LV volume overload. How you measure that isn't so easy. Relevant symptoms in infants, failure to thrive, congestive cardiac failure, recurrent respiratory infections. In adults, that's harder. You may have fatigue, dyspnea, palpitation, but you have to be aware of adults with hypertension, obesity, obstructive sleep apnea, atrial fibrillation, and previous endocarditis may be an indication. So echo assessment, we're familiar with this, transthoracic, transesophageal echo. You need to understand the major and minor defects. You need to look really carefully at the RV and LV orifices and at adjacent muscle bundles. So in terms of catheter approach, so for apical muscular VSDs or mid-muscular VSDs, a transjugular approach is good. And for anterior inlet muscular VSD or membranous, then a transfemoral. So in terms of crossing the VSD and establishing the circuit, generally a Judkins right, but you can use an internal mammary, occasionally a balloon wedge for a transmitral approach, a long Terumo guide wire, try to get a 300 centimeter one if you're going in adults, and there are even 400 centimeter ones that can be useful. A snare, the ordinary Amplatz gooseneck snare is good enough, about the same size as the branch pulmonary arteries. In terms of crossing the VSD, one of the most important things is to avoid the intercordal space and avoid the coronal papillary muscle. This is how you get hung up. So using a wedge balloon to enter the pulmonary artery where you're going to then exchange wire in the snare is a good idea. So if you can't advance the sheath from the right ventricle into the left ventricle, consider reforming the circuit, try to see what it's hanging up on, and use wedge balloons when entering the pulmonary artery. And sometimes we find hydrophilic sheaths, the Terumo destination sheath, to be quite useful. So in terms of technique, the basic technique is the arteriovenous guide wire loop, usually formed by a retrograde arterial approach, but you can use a transeptal mitral approach. I find not using a guide wire loop quite helpful. A transvenous RV to LV, transarterial LV to RV, and you can have a transmitral as well. And you can deliver the sheath in similar ways, or you may need to have a perventricular approach. But in terms of devices, mostly we're using the Amplatz, or beginning to use some LifeTech devices. You can see the congenital ones have a 7 millimeter long waist, and the post-infarcts have a 10 millimeter. But duct devices are quite useful for these. The ADO1 or equivalents, and the Amplatz or duct occluder 2 is really an excellent device for some VSDs. The Amplatz membranous VSD device, we don't use that so much because we don't do so many membranous VSD devices now, but that's the eccentric design that was good for some VSDs. So in terms of looking at approach and clinical scenarios, if it's a large muscular ventricular septal defect, the patient will often have pulmonary artery banding. If it's a small infant, we would go with a perventricular approach. If it was a larger infant or child, we'd use a transcatheter approach. Multiple muscular VSDs, transcatheter, and moderate muscular VSD with LV volume overload, failure to thrive, you could go for transcatheter closure. Looking at membranous, which we don't do so much now, but the moderate ones with LV volume overload in a larger infant, you could go for transcatheter closure. Large membranous VSDs are really handled in our hospitals by surgery. Small membranous VSDs, we leave them alone. And small doubly committed subarterial VSDs, after discussing with the surgeons, we would consider a device in some of the small cases. So other clinical scenarios, the post-op residual VSD with a significant shunt and good margins is a good one for device closure. Residual post-MI VSDs, transcatheter closure, and acute post-MI VSDs, provided the defect isn't too large, can be considered for transcatheter closure. But in a very large defect and the patient being on stable surgery may be a better choice. Look, this is from colleague Rob Martin showing a large mid-muscular VSD being closed using a hybrid perventricular technique. You can see lots of hands using epicardial echo to guide it. Here's a big sheath. And here's the device, a really decent sized device to close this defect, but with an excellent result. This is a large anterior muscular VSD with some pulmonary hypertension in an older infant, and we used a right ventricular to left ventricular crossing approach for this. Here you can see the approach, just using a right coronary catheter, just manipulated across the VSD, a Rosen wire to exchange in an ASD type sheath, 14 millimeter muscular VSD device placed. And here you see a small residual leak at the inferior part of the device. Probably just a separate defect in the edge. Here's another example, moderate inlet muscular VSD, no arteriovenous loop, direct crossing. Just put the catheter across, Rosen wire in, and an Amplatzer duct occluder 1 device. And that worked quite nicely, less chance really of it interfering with the tricuspid valve. Here's a large muscular VSD with previous pulmonary artery banding. Here you can see the defect there. Large device placed using a retrograde arterial crossing and an internal jugular approach. And pulmonary artery band dilation to remove the pulmonary artery band. Depends on how the surgeons put on their pulmonary artery bands as to whether you can do this. But mostly they will use tape with some proline suture to secure it. This is a residual post-op muscular VSD. This would have been a small infant, stuck on the ventilator, previous coarctation repair. And here you can see in this instance, we've done a retrograde arterial approach to cross it. Here is the TorqueView LP catheter placed across there. We went no guide wire loop for this. And here you can see the ADO2 device being deployed via a retrograde arterial approach. You can see that relatively tight on the aortic arch and the device being released off the cable with a good result in terms of closure of the most important hemodynamically significant defect. Moderate muscular VSD in an older infant, using an Amplatzer duct occluder 2, crossing of the defect and the wire going up into the pulmonary artery. A Rosen wire to just exchange in a TorqueView LP, and I think we might have even used a right coronary guide, but you can see we get kinking at this point because the angle is too acute, or these TorqueView LPs probably don't have a lot of braid in them. So we have to actually snare out the internal jugular vein, but we just cross the tricuspid and then put the wire up into the SVC and snare out from that position rather than go up to the PA and then pull it back. Often you can get back through the tricuspid valve with your terumo well, and it becomes less of an issue in these patients where you're using catheter for catheter delivery. Here you see the device being delivered with a good result there. This is a 3.1 kilo baby, sort of a Schoen's type complex hypoplastic arch, failed extubation. Here you can see the residual VSD that they haven't tackled. Crossing of the defect using a transeptal mitral approach. The catheter manipulated up into the pulmonary artery. JR guide then exchanged up into the pulmonary artery and the device introduced. Here you can see it's still quite possible to manipulate the device and adjust its position on echo till you get a good result. That's it released. That's it released there. For what it's worth, we also did the ASD on the way back to diminish the shunt. I mean, it certainly would have closed spontaneously if you leave it, but this whole procedure was about reducing pulmonary to systemic flow ratio in this small baby. And then you can see what the combination of devices looks. That's the 6.4 ADO1 on the atrial septum, and that's the 6.4 ADO2 on the atrial septum, and that's the 6.6 ADO2 on the ventricular septum. Multiple muscular VSDs put in 2 sessions for Swiss cheese septum. A post-fallow repair residual VSD. So here you can see at the top end, but enough away maybe from the aorta. At least we used a membranous VSD device for that, and it really got rid of his pulmonary hypertension and symptoms, and this was a 60-plus-year-old man. Problems, though, weights under 5 kilos, pinning of the tricuspid valve, hypertension, transient AV block, you need to de-air, you can end up looping across papillary muscles, sheath kinking, a residual shunt and hemolysis can be a real problem, or late onset AV block. This is an adult where we used a muscular VSD and a membranous defect with an aneurysm, and we have a small second defect that's just close to the upper end of this device. Maybe if we'd used a bigger device, we'd have got this as well. But he hemolyzed with renal dysfunction. crossing this, he came back, we brought him back to the lab, and in recrossing this or leaving across it, we knocked it out of position and we had to retrieve it from the pulmonary artery. And you can just see there's no radio-opaque band on the tip of this sheath because we cut it and beveled it to make it easier for the device to go back in from the pulmonary artery. A membranous VSD closure, and this was the patients that sort of interrupted our program of membranous VSD device closure. You can see it really quite a decent, it's not too oversized device, but 5 days later, asystole with syncope, and this really isn't you know, a good outcome for this particular, and it's sad to hear that the membranous, the second generation membranous device isn't being pushed by St. Jude. So to conclude, interventional VSD closure is predicated on good case selection and good echo imaging guidance. It can be a time-consuming and difficult procedure, and you need a flexible, anatomically driven approach, and duct devices can also be used. Thank you very much.